WKW Frontiers in Neuroscience lecture titled Evolving Neuroscience-Informed Interventions for Pediatric-Onset Mood Disorders. It is also my honor and privilege to introduce to you our speaker today, Dr. Manpreet Singh. Dr. Singh is an associate professor of psychiatry and behavioral sciences at Stanford University. She earned her MD at Michigan State University and her MS at University of Michigan. She completed her combined residency in pediatrics, psychiatry, and child and adolescent psychiatry at Cincinnati Children's Hospital Medical Center. And she's also a board certified child and adolescent psychiatrist. Her research investigates the developmental psychopathology, pathophysiology, and treatment of pediatric mood disorders, as well as methods to protect and preserve function before and after the onset of depression or mania in children and adolescents. She and her collaborators have been actively exploring pharmacological and psychotherapeutic methods of treating mood symptoms associated with and leading up to these disorders in youth. Specifically, she's examining the benefits of a combination of family-focused psychotherapy with medication in youth offspring of parents with bipolar disorder to reduce mood symptoms and family stress. And finally, they have been conducting studies examining the neuroimaging effects of pharmacological and psychosocial interventions, specifically exploring whether such interventions can reduce limbic hyperactivity and increase prefrontal cognitive control. Dr. Singh has been awarded several NIMH awards integrating innovative neuroimaging techniques and mechanisms of emotion regulation to understand the neurodevelopmental basis of mood disorders among children. She has many honors, but to highlight some of them, she has received the Narsad Young Investigator Award, the Klingenstein Third Generation Foundation Depression Fellowship, and the American Psychiatric Association's Young Minds in Psychiatry Award. She was also selected as the Akiko Yamazaki and Jerry Yang Faculty Scholar in Pediatric Translational Medicine. Finally, Dr. Singh has family ties here in Oklahoma and has served as a mentor on my Cobre Career Development Award, which investigates the effects of neurofeedback, augmented mindfulness training on brain function in adolescents with childhood maltreatment exposure. It's a real treat to welcome you, Dr. Singh, to LIBR and Tulsa, even though it is snowing today for us. So I hope you're staying warm in California, but please join me in welcoming Dr. Singh. Thank you.
Thank you, Namik, both for the kind introduction and for the honor of having the privilege to mentor you. It's just been a delight, and I'm very much looking forward to our conversation today. I'm going to share my screen now and request that if you have questions for me during the course of my presentation, to just give me a shout out, because I won't be able to see you while I present. These are my disclosures of potential conflicts. I do collaborate a lot and will not promote any healthcare products as goods during my presentation, and have resolved the conflicts that you see here with the St. Francis Health System. Today, my hope is that we can spend some time talking about how mood symptoms present in youth, utilize current neuroscience knowledge to guide us towards developing better evaluation and treatment strategies for pediatric mood disorders. I'll describe three studies that we're doing experiments in youth with and at risk for mood disorders, if you will, that hopefully make progress in our approach to these youth and families. And finally, integrate knowledge from prior intervention studies to design new clinical trials. I'm always ever seeking the next best design that can help us towards better implementation of our current treatments, but also discovery of novel therapeutics. And I think personally that there's no keener revelation of a society's soul than the way in which it treats its children. We haven't vaccinated our kids yet, but we will at some point. And the value of working with children from my perspective is that I'm a doctor who's in the business of preventing chronic illness. And so with that lens in mind, I hope you'll find the portfolio of science that I'm presenting to you interesting. It's really principally aimed at meeting clinical unmet needs in pediatric mood disorders and to cultivate hope in patients and families. So why do we care about this problem? Want to just kind of highlight a few characteristics of mood problems that can have the potential to last a lifetime. The ones that do last very, very long periods of time tend to start early. For most adults with mood disorders, the onset occurs during childhood. And mood disorders tend to be chronic. And when they start early, they tend to also have poorer long-term prognosis and increased risk for suicide compared to adult onset mood disorders. They're frequent and they're increasing in prevalence. Mood disorders diagnoses are maybe increasing because we're recognizing that kids too can be sad and stay sad for long periods of time. But I think that it's perhaps also an appreciation of something that's always been true. And now with better tools and sensitivity to understanding how these things manifest in kids, using language that's more developmentally appropriate, we can get at better understanding these phenomena in kids. And finally, these conditions are complex. Mood disorders don't tend to run on their own. They tend to run with other things or have other things start before they take onset. And because of these comorbid conditions, you often see complexity in presentation, sometimes resulting in diagnostic confusion and for sure confusion in treatment approaches. So with these issues in mind, we have some understanding of what's happened in the past and what we need to potentially do to move the field forward. We recognize that in very much the pediatric depression literature, even more so than in adults, pediatric clinical trials in depression are dominated by what we call symptomatic improvement with non-specific clinical contact. Non-specific clinical contact is what you get when you come to a research study or to a doctor's office and miraculously feel well even before the doctor has had a chance to prescribe or do any implement any intervention. It's that effect of socially interacting with someone who is oriented to helping you that is very powerful. And we need to understand that phenomenon more so that we can leverage it. The other point to make about most interventions to date is that they've had a rather modest added treatment effect. So incremental to above and beyond what you get from a psychotherapeutic intervention in kids, you get these, 10, 20% additional buy-in treatment effects from adding pharmacological treatment to a psychotherapeutic intervention. Most kids don't receive full or achieve full remission even after they've been in treatment for very long periods of time. And adding CBT has some selective benefit for very suicidal teens and may have some prophylactic effect in preventing future episodes, but we need to understand that more. The other problem that we face in the field is that depression is clinically heterogeneous. It is a different beast for different people. And for that reason, we've all pivoted towards understanding personalized conceptualizations of depression. What does depression mean to you and how does it affect you? And how can we match the treatment according to what matters to you? That's both important, but also problematic from the perspective of designing treatments that can have maybe a single or impactful or focused effect. Another important challenge is that longer term effects of mood symptoms and treatment are unknown. Most of the clinical trials that have been done in pediatric mood disorders are acute studies that involve 6, 8, 12, 16-week interventions. Some of them have gone on to do more longitudinal or maintenance observations, and those studies are emerging, but we need more of them to better understand not just whether you can get acute symptom relief, but what do you need to prevent the next treatment, relapse, symptom relapse. And if you're like me, and you see patients in the clinic who say, perennially ask you, hey doc, how long do I need to be on this treatment? Can I stop my antidepressant now? Can I stop coming to therapy? And what are the parameters that you provide that psychoeducation to patients and families? Another important challenge that is unique in some ways to children and pediatric presentations of mood disorders is that sometimes kids can present with the concurrent elevated mood and a low mood. And those mixed states are not just common, but often can be very problematic for treatment planning, because sometimes treatments can worsen mixed states if not identified appropriately. So this phenomenon needs to be better understood and studied in terms of understanding and treatment. Let's just talk for a moment more about placebo responses and why are they so common. In a recent study, there was even perhaps I suppose, a downer for our field to recognize that what we think predicts treatment response versus placebo may or may not be that informative to us as a field. There was a recent meta-analysis done by Andrea Cipriani and others. But what I want to point out here is that, the one-thirds rule seems to apply very frequently in pediatric medicine, where you see that response rates tend to be kind of divide in thirds. In this Kate's plot depicting benefits of antidepressants versus risk for suicidal ideation, so benefit versus a risk of suicidal thoughts for pediatric patients with anxiety disorders, about a third get better on both placebo and antidepressants, about a third get better on antidepressants but not placebo, and about a third get better on neither antidepressant or placebo. And then you have this risk issue. So you've got the benefit piece figured out here in this thirds rule of thumb. And then you have this small group of people that have suicidal ideation on antidepressant, but not placebo. And this is really what's resulted in the black box warning. But when you think about the relative risk of this compared to benefit, it's hard to imagine why we would withhold treatment for depression because of this very, very marginal risk. And so this has certainly played out epidemiologically after the black box warning worldwide. You saw an increase of depression worldwide, and further problems. I guess you could apply this same risk-benefit analysis to vaccines and the recent concerns about blood clots with both the AstraZeneca and Johnson & Johnson vaccines. The relative risk of the blood clots is very, very small compared to the broader benefit, but our discussion ends up being focused on the risk. For good reason. We don't want to inadvertently do harm to patients, but we need to understand harm and how it plays out and systematically evaluate adverse effects in our clinical trials in a way that helps us understand its relatability to the treating drug versus placebo, as well as its potential to have risk in a broader population. Another sort of concept to think about is the placebo effect. I had alluded to this before, that the placebo is a very interesting phenomenon. If we understood it better, perhaps we could bottle it up and leverage it. Wouldn't it be great that you wouldn't have to do much except non-specific clinical contact with patients, and they get better? Doc, I'm cured just by seeing your smiling face. Well, what is it about the placebo effect that has an impact, and how do we understand it? I think that now in the digital world and in the realm of being able to communicate and do telehealth and even do treatment delivery through this kind of an interface, we might be able to actually systematically understand this, understand the non-specific clinical contact, or even the benefits of just psychoeducation or teaching, learning information versus something that requires more skill building. Could we do that more effectively in person versus through a screen? These are frameworks that we have been thinking very deeply about to understand and delineate treatment from placebo effects. And we're engaging with scientists who are very interested in mindset, as so that we can better understand concepts like mindset towards getting better, trust, and expectancy, as well as other social and contextual factors, like again, the power of being next to somebody in implementing a therapeutic response. That non-specific clinical contact, does it go away when we no longer see patients in person, or are we able to do something? Is the substrate of that non-specific clinical contact retained or maintained in a virtual environment? So we're brainstorming on this and thinking a lot about and deeply about this. I welcome your input and interest in that. So for treatment of pediatric mood disorders, the current state of the art is aiming and gunning for remission. Ideally, we want kids to be well. We want to formulate target symptoms, manage side effects, manage comorbidities, not just treat the patient, but also the system, and also address the impact of chronic, negative, and stressful life events, school issues, and family conflict. And it's where I find my discussions with Namak very enriching, because we have a chance to kind of think through how do you treat the individual in the context of a broader system. Point to this clinical handbook that we published a couple of years ago now, that is available. It's clinically oriented to provide the practicing clinicians with some fundamentals on approach to the diagnosis and treatment of mood disorders in kids, and I hope you'll check that out. I think that it's important to recognize and appreciate with humility that we are not interested in magic bullets anymore in medicine. We've put a lot of investment in developing single targeted mechanisms, and I think with humility we are increasingly appreciating that, in particularly in complex phenomenology like mood disorders, a single magic bullet isn't going to be enough. The conceptual framework of a chemical imbalance isn't going to be enough. And so multimodal treatments are going to become more the norm rather than the exception, and should be tested both in randomized controlled trials that are empirically designed, but also in real world settings where we can get input from patients to understand, is a decrease in symptomatology enough for you? And in the business of trying to match more treatments to patients with very, very specific subtypes of depression, we can see webs and webs of complex networks that we develop on all of the epiphenomenon that contributes to the presentation of a mood syndrome in kids, and feel quite disparaged by the fact that precision psychiatry may or may not give us as much bang for our buck as we'd wish for. It might be more noise than signal, but I think we owe it to our patients to think very deeply about how to personalize treatments, whether it's using risk calculators or algorithms that are informed by artificial intelligence, or through more careful diagnostic formulations that help us understand the very specific nature of these mood symptoms within specific contexts. And we also need to understand and balance that Symptoms are also buffered by remodeling and adaptive plasticity. Our brain is very, very nimble, and it has the capacity to respond. And so it's also our obligation to know, particularly in kids where side effects can become more problematic than for adults, to know if there are internal or intrinsic mechanisms that can be harnessed towards preventing mood symptoms, and utilizing those as maximally as possible. Whether it's exercise or sleep regulation, foundationally, or assessing dietary choices, evaluating temperament and readiness, again, towards understanding mindsets, towards making changes in behavior that can have more definitive effects to prevent the chronicity of mood disorders from taking hold. So this formulation, after many years of looking at evaluating youth with very serious mood disorders, is my rather simplistic and evolving formulation of how mood symptoms come about, and how they evolve and lead to not just episode development, but also recurrence. And that there's probably, in a non-specific way, a very important interaction between prefrontal and subcortical systems of the brain that are involved in emotion processing and regulation, that are clearly engaged and end up being very important modulators for treatment response. So in the business of treating and preventing mood disorders from lasting a lifetime, Tom Insel a few years ago formulated kind of three major areas of research focus. We need better biomarkers for early detection. We need preemptive interventions for those at risk or in pre-symptomatic stages, and we need better treatments for people living with depression that predict and track outcomes. And I think that this roadmap still holds true today, and many of us are iterating our science along all of these different strategies. In my lab, we focus on several strategies because we understand that there's a clear need for a call to action. We believe that better treatments needed to exist yesterday for kids, and so we're doing our best to try to iterate on that science through measurement of individual and family factors for risk and resilience from developing mood disorders, leveraging neuroscience to understand how mood disorders emerge and test the safety and effectiveness of developmentally informed interventions, as well as harnessing cutting-edge computational innovations to predict outcomes. And at the end of it, translate science, preclinical to clinical, bench to bedside, bedside to bench, to meet clinical unmet needs. It's not just now a forward translational concept. In my mind, discovery science and applied science need to work hand in hand and iteratively to achieve benefit. So how do we investigate resilience? I'm going to show you now some slides, and I'm going to go through some data that we've now preliminarily shown that contributes to iteration on this science. First, on the concept of resilience, which we know is a dynamic and complex process. It's defined as the ability to adapt successfully to adversity, stressful life events, significant threat or trauma. And it's on a continuum and can be cultivated with the potential for change across the lifespan. Our colleagues in Mount Sinai have provided this nice infogram that I like to show about, concepts that we all know and exist in our lives, all the time, that we engage with to manage stress or stressful situations. What I'd like to focus on in particular is the concept of training your brain and establishing and nurturing a supportive social network in particular over the next few slides. Here, the other concept to introduce is that, it's a family history of a mood disorder, either depression or bipolar disorder, that we use as a model system. these are my kids at a younger age. I have a third now as well, but on any given day, they love each other and are very cuddly, and also at each other's throats, literally. And so, we all know that we all have good days and bad days, but who are the kids who are going to have more bad days than good, and who are going to go on to develop a chronic mood disorder? A few years ago, we did a family study of offspring of parents with bipolar disorder and compared them to offspring of parents without any psychopathology, all in a stage of health. So you couldn't differentiate them behaviorally. They all looked healthy. They didn't have any mood symptoms. But what was strange was that the kids who had a bipolar family history, those at high risk, showed a disconnectivity in the prefrontal striatal regions that ended up actually correlating with more chaos, family environmental chaos. This clued us into the potential effects of environmental family stress on brain development in kids who have this, again, two-hit in both biological or familial propensity towards mood disorders, but also compounded by family chaos. Imagine growing up with a parent with recurrent manic and depressive episodes. The problem is that many of those kids don't go on to develop bipolar disorder themselves. Some of them go on to develop depression, anxiety. Others are resilient. So we're very interested in following these kids over time to better understand what factors contribute. And indeed, we've invested in brain imaging strategies to better understand this, because imaging has been a useful tool for us to understand behavior and the origins of behavior in the neural circuits, because it's clear that neural circuit changes can potentially occur even before the onset of symptoms. And so could neural circuits end up being then viable early biomarkers to help us understand a trajectory towards chronic mood problems? And when we did an analysis of kids at risk for depression and compared them to kids who already had depression and healthy controls, it was very clear that the brain could be delineated using amygdala seeds and nucleus accumbens seeds in the brain to delineate risk markers, markers that help us understand who has a familial risk for a mood disorder versus a kid who has already developed depression, so disorder markers. And that level of granularity is very exciting in our minds, because it can potentially lead to staging strategies that help us then understand what the level of risk would be, as well as how can we intervene and at what point we need to intervene. So our risk and resilience study started off with offspring of parents with bipolar disorder who were healthy and healthy controls, and then we expanded it to include offspring of parents with depression. And so the sample size is about 150 all told. And we evaluated them again from a stage of health, and we followed them on average now for about, it's been about 8 years and almost up to a decade now. Some of these kids have been followed and staggered in terms of recruitment, not by design, but just the way that things go in research and funding. And what we found was that when we followed up on these kids, the kids who had bipolar risk and depression risk were much more likely to convert to developing some sort of a mood disorder. It turns out that all of the follow-up diagnoses that any of these kids converted to were some form of an internalizing disorder: major depression, generalized anxiety. Very, very few, if not only one so far, has developed mania, social anxiety, and panic. So the internalizing disorders seem to be sort of this, perhaps continued, risk towards developing the unilineal outcome, though multifinality is also possible with more time to follow up. When you look in the brains of these kids at baseline and then relate them to potentially diagnostic outcomes, you see some very interesting findings emerge. And across groups, you don't necessarily see significant predictions that delineate resilient from converted on the basis of connectivity alone at rest. But what you do see are clear trends for stronger limbic and striatal resting state functional connectivity in the amygdala, as well as in the ventral striatum. So this, stay tuned. One of the things that my postdoc did here is a test training split looking at longitudinal mood or anxiety disorders outcomes, and found that the functional connectivity in emotion regulation and limbic circuitry was able to predict resilience versus conversion with approximately 73% accuracy. So we're getting there, but we have some more work to do to perhaps iterate towards more accuracy on how imaging might predict clinical outcome. And what's interesting is that there are important moderators for conversion, including a more rigid family environment, which will also evolve to writing up here in the next few months. My graduate student, Akua Namarco, who'll be defending next month, has done some beautiful work looking at emotion processing, and she's also looked at reward processing now in this sample of youth. What she's discovered, and certainly knows from clinical context, is that offspring of parents with bipolar disorder seem to have some unique risk factors for key social deficits, and their lack of awareness of positive social stimuli could herald potential peer problems and could increase the risk for developing mood or anxiety disorders. And what she's found is that it's very clearly the case that their peer problems seem to be associated with decreased putamen to posterior cingulate connectivity, as well as a higher risk for conversion. When she looked at the flip side of the question in terms of resilience and conversion, what she found was that stronger connectivities in the inferior parietal lobe to the precuneus seemed to predict more prosocial behaviors that were derived from the strengths and difficulties questionnaire that allude to more prosocial behaviors. So stronger network connectivity correlates with increased prosocial behaviors from baseline to follow-up, whereas weaker connectivity seem to be associated with conversion to a mood disorder and peer problems. So interesting that in this developmental stage, where in adolescence, where peer interactions and peer reward, peer socialization is and social reward is intrinsically paramount and salient for these youth, that these constructs are coming out and showing some relation in the brain. So if we were to cultivate pro-social behaviors so that kids are just a little bit more empathic, more inclined towards developing connections with each other, rather than having problems with each other, could we potentially improve their ability to stave away mood and anxiety disorders, and potentially prevent the conversion to a mood disorder lifelong? So could we cultivate pro-social behaviors to change the brain and then change the outcome? Well, how do we do that? You can cultivate pro-social behaviors in a variety of ways. And now I'm going to allude back to the fact that we very commonly in our interactions clinically, non-specific clinical contact with people starts off oftentimes in medicine with psychoeducation. We educate people about the symptoms that they're experiencing. Oh, these mood symptoms that you're having are part of a constellation of symptoms that can occur. We call it depression or something, whatever you want to say, and you know, it seems like you might be experiencing these symptoms over this period of time. Let's talk about and understand those symptoms together so you can track them. That's psychoeducation, and what we call that typically is, it may feel like non-standardized, but in many ways it is standardized. It's something we do as a first step even before we provide skills. But say now you add some pro-social behavior training. And I conceptualize much of what we do in CBT in terms of communication skills building or problem solving skills building as really at the end of the day to achieve the goal of increasing prosociality. Can we get to a place where we can actively listen to each other or solve problems together or provide feedback to each other so that we can collaborate more and work together as a system to address the problems in our family? If in the family system you do this combination of psychoeducation plus this pro-social behavior training, you come up with this thing called family-focused therapy. And family-focused therapy is an intervention that we've now had the opportunity and privilege to collaborate with Dr. David Miklowitz at UCLA on for years, and randomized high-risk offspring of parents with bipolar disorder to either family-focused therapy or just an enhanced care control condition, where kids get roughly the same amount of time in either or. And when you look at the outcome of this trial, what you find is that in the acute phase of treatment, in the 16 weeks that the family-focused therapy and the enhanced care is administered, there really isn't any separation in symptom improvement. But when you go now up to 2 years out, you begin to see that there are durable effects of family-focused therapy in delaying depression recurrence compared to just providing psychoeducation alone. So this pro-social skills training may not look like it has much of an acute effect, but in the long term, it seems like it's preventing recurrent depression. Let's look at what it does to your brain. We did an independent components analysis of resting state data in youth at risk for bipolar disorder and compared them to healthy controls. And what we found was that the ventrolateral prefrontal cortex had relatively increased connectivity to the anterior default mode network. And this was observed more so in high-risk offspring of parents with bipolar disorder compared to controls. And when you looked at the treatment effect and compared the family-focused therapy with enhanced care, you saw, in fact, an almost increase. It was a statistically significant increase in that ventrolateral prefrontal cortex to anterior default mode network connectivity, enhanced with family-focused therapy compared to the psychoeducation alone and in the healthy controls alone. And what you see also is that that increased connectivity corresponded to improvements in depression severity. This is very interesting to us because we wonder if family-focused therapy in the pro-social skills training components are improving pro-social behaviors, improving emotion regulation, targeting parents' expressed emotion, so treating the system, improving the quality of family relationships and physical well-being, or acting as an interactive effect between medication and psychotherapy to improve adherence. The most intriguing possibility in our mind is the potential for neuroplasticity. Is it possible that we have, by administering family-focused therapy, in fact, improved the brain's capacity to adapt to this chaotic family environment in which these kids live, and shored up connectivities that are critical for emotion regulation to prevent the recurrence of depressive symptoms in 2 years, or in the acute phase, though you don't see statistically significant differences between enhanced care and family-focused therapy. In depressive severity, you do see clearly a brain-based difference between family-focused therapy and enhanced care. And to me, that just reflects what we saw in our risk and resilience study. You see neural plasticity occurring and preceding symptom manifestation or change. I want to just kind of comment also on the fact that symptomatic recovery seems to be such a focus of clinical trials, whereas most of our patients who come to our office say, you know, Doc, I don't really care if my depressive symptom score went from a 50 to a 29. what I really care about is getting back to having friends again, or doing well in math. And the functional recovery ends up becoming really important. And in this post hoc analysis that we did in our family focused data, you can see that symptomatic recovery has different trajectories compared to functional recovery. And so we really ought to be thinking about these kinds of concepts as well as we're designing new studies. In the moments that I have left, I want to just kind of zip through a few other concepts for you. And how we're thinking about them. If someone, I think Anna, could you maybe mute yourself so that we can reduce background noise? That'd be great. Thank you so much.
Sorry.
Not at all, not at all. Thank you. If you have a question, don't hesitate. Anybody can stop me at all. It's no problem at all. I'm not fazed by it at all. But just wanting to make sure that I get through some of the content here before, so we have enough time for questions. Comorbidity is a rule rather than the exception. We talked about this before. Early life stress contributes early and significantly to brain development. Antidepressant treatment response in youth modestly separates from placebo. And we know that we have to use combination psychotherapy plus medications to get the best short-term results, but we don't know how long those acute responses last. So when you look at the brain and try to understand these model systems, particularly from a reward system perspective, it's very important to think about families who have children who present to us clinically who have compounding problems. My kid is depressed and gorges on ice cream and junk food to try to make him feel better. It helps him in the short term, but he then becomes even more depressed, and there's this vicious cycle. What is that vicious cycle? Well, we think it's a prediction error signal. In the reward system, where kids who are approaching reward seem to be expecting that eating junk food is going to give me relief from my depressive symptoms, but it ends up causing weight gain and other challenges, and interacts in a very complex way. When we did the literature review of depression and obesity in kids, we found the same neural systems engaged in reward systems engaged in these behaviors. And we wondered what would happen if we evaluated kids who had both depression and food-seeking behaviors, and what would that do to their potential for developing worsening or chronic depression, but also their risk for developing cardiovascular disease and diabetes down the line. So we wanted to do a kind of a first step proof of concept study to observe kids over a 2-year period who really were at high risk for developing these co-occurring conditions, and look to see if we could understand whether early changes in their neural systems could lead to worsening depression outcome. And it's a longitudinal design in 120 overweight girls and boys, treatment seeking for depressive symptoms, assessed at baseline 6 months and 24 months. And we're just finishing up our 24-month follow-ups in these kids. We scanned them multimodally at baseline and 6 months to look for early neural mediators for behavioral outcomes. And in our preliminary evaluation of their behaviors at baseline, we've definitely now demonstrated that there's very clear correlations between insulin resistance and behavior, structure, and neural connectivity that also correlate to depression. So the worsening depression, the worsening levels of insulin resistance seem to correlate and correspond to structural smaller volumes in the cingulate, dysfunctional intrinsic anterior cingulate and hippocampal connectivity to the reward system, as well as important moderating effects of exposure to victimization or abuse. A lot of kids with depression and obesity are bullied, and as a result show very, very high levels of victimization. We've looked at it both from the perspective of peer victimization, but also history of early life stress using the CTQ, or the trauma questionnaire, childhood trauma questionnaire. And what we found is that you can actually very clearly see a moderating effect of high versus low abuse on neural networks and their relations to insulin resistance and depressive symptoms. If you tried to now package this information into a potential treatment, you could look at neural correlates of intervention effects. And we here with our collaborations with Natalie Rasgon and others who are very interested in the interaction between depression and insulin resistance have demonstrated that liraglutide can actually improve on that connectivity between the hippocampus and the default mode network. And baseline fasting glucose seems to be associated with greater connectivity. We didn't see cognitive benefits from liraglutide, but there's clearly a need to further investigate these relations towards more long-term outcomes. So multimodal treatments are the rule rather than the exception in kids. Here are the FDA-approved treatments for depression in kids. You've got just two, fluoxetine and escitalopram. And for bipolar disorder, the grid is a little bit more populated, but you still have some unmet needs. The one thing that we don't know is how we should treat depressed youth who have a high risk for bipolar disorder. If there's a family history of bipolar disorder, you'd start with therapy first, but then what do you do if that doesn't work? Do you give them an SSRI, bupropion, lamotrigine, lithium, quetiapine? We don't really know. And what we found is that kids who have a family history of bipolar disorder, and if they're young in particular, have this interactive risk or propensity towards developing mania after exposure to an antidepressant. And there's an age effect. So the younger you are, the more likely you are to develop an adverse reaction to an antidepressant. And what we've seen biologically is that these kids who do end up having an antidepressant related adverse effect have smaller amygdala volumes as well as amygdala hyperactivity. So there's clearly a need to understand what factors might predispose a kid to developing a side effect from an antidepressant if you were trying to treat their depression versus not versus benefiting from it. And so we're doing a randomized controlled trial to better understand this systematically, where we randomize offspring of parents with bipolar disorder to Lexapro or placebo. We already know Lexapro works in kids. We've done those clinical trials, but we haven't done them in these high-risk youth to understand their propensity for developing side effects. And we're doing some imaging concurrent to that to better understand the mechanisms, biological mechanisms of switch or adverse reactions compared to placebo. We're using advanced computational analyses to also understand sex differences in youth who have a risk for developing internalizing versus externalizing psychopathologies in kids, recognizing that latent variable classes may be more predictive than single variables, but we need to translate these to clinically relevant outcomes. And we're also taking a stab at collaborating with industry partners to look at digital therapeutic strategies like a web-based or an app-based intervention. Particularly in the pandemic, this becomes potentially useful. When we get back in, I'd love to be able to continue my intermittent theta burst stimulation study in treatment refractory kids. We're working on that too, so that the kids who are struggling to fail every other treatment under the sun can have options like direct brain modulation. And, you know, we know that there are clear challenges as well as pipeline strategies that we can think about towards developing better treatments. For youth, we need to understand safety more because kids are just more sensitive to adverse side effects, whether it's from a psychosocial intervention, which is much less likely to cause a side effect, but still can. You know, as we develop or implement much more accelerated strategies or strategies that seem to have acute benefit like S-ketamine or transcranial magnetic stimulation, we need to do a real assessment of its safety profile in kids. Think about complementary treatments, leverage the placebo response, and collaborate. I want to end kind of on this, on a note about being sensible in medicine. Many of us in the research area think about critical sensitive windows, risk-benefit ratios for intervening, or just waiting, watching, and wondering as to when, kids' innate capacities for self-correcting or adapting can kick in before we actually need to do something about their mood symptoms. And we're really at an interesting inflection point, maybe with the help of a pandemic, to critically evaluate progress and practical challenges in medicine. And I think that it's very important for us to be very humble and not necessarily put our eggs into magic bullets. Magic bullets don't work in brain health, so we have to recognize that highly selective, fully effective treatments are uncommon in acute care, and personalized approaches will require more than biomarker innovation. We have to practice doing almost nothing, because the placebo effect is real, particularly in pediatric depression. We have to elevate usual care. We can't forget to take care of everything that comes with treating psychopathology, like co-occurring sleep, sedentary lifestyles, dietary preferences that come with mesolimbic adjustments to social isolation. We have to focus on high quality evidence. It's really important. Some clinical research is biased. Even the best research methods like randomized controlled trials can be unreliable. And this has been amplified by the rapid pace of research undertaken during the pandemic. And so if there's this public demand of an effective intervention, we don't want to generate unwarranted visibility or sensational results from small, unblinded, non-randomized trials, as illustrated with things like hydroxychloroquine. So to be confident that an intervention is effective requires our reliance on evidence from only the highest quality randomized trials. I also think we need to think Bayesian. New treatments are a bit like the proverbial new kid on the block. They have an allure that is hard to resist, but the prior odds that a new treatment is effective are pretty low, given the lack of a unifying biological mechanism and multiple neutral clinical trials. This is where I think we need to be humble. We have to learn from our past, the placebo effect being real, that we don't have a lot of very good treatments for very bad treatments, that we're balancing risk benefit, and that we don't know anything yet about durability. But we can use these translational concepts and methodologies to be able to iterate. Because kids are not mini adults, early signs of neurobiological dysfunction can occur even before symptom onset. There are safe and effective treatments that exist, and we need more combination interventions. I'm going to put in the chat a link to an article that I wrote about my sister, who's pictured here. And I'd love if you would like to tweet about it. Here's my Twitter handle. It kind of provides me with a perspective of where our science needs to go and where our priorities should be, because kids are resilient, and knowing when to treat them versus allowing adaptive mechanisms to kick in is worth pursuing. I'd like to acknowledge our village and thank you for your time and attention. Please do reach out and contact me if you have any questions, and I'm going to stop sharing and share my my article about my sister, and I'd love to hear your questions in the remaining time that we have.
Thank you, Manpreet. Great talk. We'll open it up to questions.
Manpreet, maybe if I can just jump in. One of the things that was particularly interesting in listening to your talk is the how to think about resilience and fostering resilience in kids, and particularly, and then how to connect that back to sort of the underlying neural systems, or the kind of hardware, so to speak. It's not really hardware, but you know, that's so how do you think about that in what are your you talked about you know, that one way to think about the symptoms as they emerge is within the context of, say, a prediction error or some reward-related processing. So can you then kind of extrapolate from that to what you would do to make kids more resilient in preventing sort of this aberrant prediction error emerging.
Yeah, for the reward system, one of the thoughts that I've been kicking around with Ian Gottlieb and others, and Brian Knudsen, who did some work with, just real-time training, right? The idea that could we actually take the monetary incentive delay task and try to train people on being able to be more effective at the task itself doesn't really do much more than conceptually understand anticipation and feedback of reward systems. So I think it gives you a sense of a hedonic or anticipatory reward function. Learning, however, on the other hand, I think is a very different construct. And so when he did reward training real time in the scanner, he saw that you could actually modulate NAC, but it only lasted, the effect of NAC training only lasted like what, seconds to minutes. And so the durability of that training seems, again, unclear. For a while, I had proposed that we do something like or develop a sort of a prediction error learning paradigm where people are trained to correct a prediction error, if you will. And I think that that's something that I would like to actually learn more about from your experience, because if you can actually correct the error, the prediction error, then that's really in essence what I think these kids with depression, food-seeking behaviors need, right? They need to, and is dieting or is just a kind of a more global behavioral interventions actually getting at that? How do you think about this? Because these are the things that we've been trying, but we're not sure. First of all, we're not sure that NAC training is going to be enough. So direct modulation of NAC is going to be enough. The behavioral paradigm seems to be kind of confusing because there's so many reward paradigms that tap into different sub-constructs that it becomes very muddy to figure out what exactly we're doing.
Yeah, I mean, so I completely agree. I think that the monetary incentive delay task is one way of measuring the acute blip that somebody might experience if they're experiencing the anticipation of something good happening. I don't know whether that necessarily will be sort of the focus of, from my perspective, it may not give you we know, first of all, we know that people with depression, that signal is squeezed, right? And that is not as strong, and therefore maybe motivated behavior doesn't take place. I was thinking more in terms of the other side of things, which is once you have that signal, what do you do with that signal?
Right.
And so one thought that I had, and we've looked at this a little bit within the VMPFC, is to could one learn to savor the positive effects of what's happening to you? And often that, of course, comes from other areas that, some which may be bodily related, like the insula, but some may be more value-based, like VMPFC. And so the idea would be, and I think that in some sense, I'm sometimes wondering about that a little bit, that in our current world, we don't really learn how to savor, because we kind of go reward after reward without necessarily kind of enjoying what actually that means, right? What's the consequence of that? That's what I was thinking of, maybe where you could go with, particularly within the reward context. It's not the only context, but it could certainly be something that where you could bring the neuroscience together with learning something that actually might consist of not just learning your reward system. It might have to do with mindfulness, right? It might have to do with other higher order processes.
Absolutely. And I think that I would only add to this, the context of social neuroscience and its salience and relevance to adolescents in particular. What do they come in asking for, right? Most of them are really very preoccupied with their peer relationships. And so the family-focused therapy work for me was very interesting because you could see prosociality and training on prosociality having a brain-based effect. So to me, that could be, in other words, you know, you have to choose what you're savoring. We've done experiments in our observations of the depressed, obese kids on monetary and food related rewards when social rewards end up being really relevant or important. And so Erica Forbes talks about social reward and has others have really worked on that concept. But how do you savor a social reward? Really, it's through cultivating functional relationships, right? So that practice and then being able to understand the neural substrates of that, I think, is very interesting. But in the complex brain where multi-systems are working, you know, whether it's in interoception and then although also the interaction with the external world, the physiological responses, the models become very complicated very quickly. But I like the way that you're thinking in terms of that multi-system approach, and I think that for adolescents the experiments are really quite intriguing around social neuroscience. Thank you. Other questions?
So how does puberty play into all this? Like, for instance, the difference between prepubescent, during puberty, late adolescence, the onset of mood disorders. I mean, are there clear distinctions there, or yeah?
We need to better understand. Of course, I think there's a recognition very generally that puberty has a very clear effect on the brain and brain development. How to systematically understand neurohormonal effects is a curiosity. I think that people are looking at brain-based evidence for pubertal effects, and you can do that by looking at secondary sex characteristics. People think that that's, you know, less rigorous than peripheral hormones like testosterone or estrogen levels, and then correlating them. But I would just caution all of us to be very thoughtful about how we relate peripheral markers to central functions. There are clear relations, but there are also pitfalls, and you know, I really like the idea of us staging puberty according to brain-based markers. Martin, do you know anybody who's actually doing that with ABCD or otherwise? Because I think that that would be so interesting to stage the brain according to pubertal development.
I know that several people are working on the peripubertal assessment in ABCD. I don't know who the specific person, but you know, that'd be straightforward to find out.
There are certain scientists, I know Natalie Kolick from Ian Gottlieb's lab was very interested in this phenomenon, and the design of the studies have always been sort of, you know, comparisons pre-post or looking across development. I think that the transitions across development and sampling in individual variation across time, but also across ages, I think will be very, very useful. Just to kind of state that, you know, we have seen pubertal effects, and we covary for puberty. We look at Tanner stages. We look at the effects of puberty on our data. And control for it. But I think as a variable of interest, I totally agree, Bart, that we ought to do a more granular assessment of pubertal development in its concurrence to psychopathology onset, because there's very clear hypotheses that hormonal changes absolutely have an impact on the development or escalation of psychopathology. Martin, I wrote my first Director's Innovator Award on this that got triaged and never saw the light of day. But then I did some follow-up studies. We iterate our science, but Bart, I thought that was so important that I even tried to really shoot for lots of millions of dollars for it. But NIH didn't think it was interesting at the time. But maybe if others are interested, we can come up with a study that makes sense. Well, I know we're past the hour. I don't want to delay anything if people need to carry on, but I'm absolutely happy to hang out for longer if people would like to chat.
Well, I had a question about, we've talked about the social neuroscience, savoring social experiences, and the effect of pro-social behavior kind of as an outcome. I wondered if have been any attempts to incorporate like volunteer behavior as a kind of a treatment modality to kind of encourage all those things.
Yeah, I think that's a great thought, and maybe doing more systematic studies that are designed at actually modulating prosociality more directly like that, or designing studies that get at different levels of capacity for prosociality. You know what this is all rooted in, from my instincts, was actually prevention medicine, the old experiments that people did for kids who had really bad behaviors in school. And in the 1950s, these scientists developed the good behavior game. And then, this is the largest prevention science experiment that's been done. And it's been followed now generations out, where the kids who got classrooms that got randomized to a good behavior game versus not ended up being really, really very, functional members of society. And those who didn't get it, who were particularly vulnerable, were much more likely towards delinquent behaviors. So, taking that and narrowing that down to more very, very specific experiments that look at prosociality and its capacity to prevent psychopathology, I think is just, it's why I've focused so much attention on this recently, because I think that for resilience and the context of resilience, in adolescence, social behavior and cultivating pro-social behavior seems to be a very important early preventive strategy, and it's worked in prevention science. Now we need to show, maybe showing some biological basis for it might actually result in us reinvigorating why we should wear a mask and care for others, and could maybe help at a more societal level. Yeah, I love that idea. Thank you, Adam.
Thank you.
Maybe one more question, and so get us to 1:10, and then we can wrap up. Or not.
I had a quick question. I was interested you mentioned that you were doing theta burst stimulation with the kids. Were you pairing this, kind of going back to the training and kind of learning question, were you pairing this with some sort of training, or was it paired with therapy? I was just interested. I do some neuromodulation work myself, so I'm always interested to hear.
It's a great question, and I think that actually our designs should look at interactive effects or design studies that enable us to do maybe staging. Or the problem with some of these designs is they get really complicated in terms of control conditions, and how do you then develop arms that are like adequately powered and whatnot. But the quick answer to your question is no. I'm throwing spaghetti at the wall and looking for signals. No, I'm actually doing very. I'm trying to actually really understand fundamentals on interventions and see which ones might actually make rational sense. But part of it is it goes back to that insole slide where I kind of talk about, like, our need to kind of integrate biological markers with early risk assessment and iterating towards better treatments for people who are already suffering and failing everything else. I think theta burst is interesting, but again, it's going to be another one of those acute things that we have to figure out the durability of. Nolan Williams and I are collaborating on this, the theta burst application in kids, and his science is very much focused on like stacking treatments to get kind of essentially get at like deep brain stimulation level stimulation in the brain to like get at shorter periods. And for practical reasons, that actually is really cool for kids, because which child has the interest in, sitting for 30 minutes every single day for 6 months? I mean, it's just not practical. Yeah. And the safety profiles are looking good. And so I feel very confident that we could potentially use this. Why are we thinking about this in kids? Well, just to kind of allude to my first point, that kids have really bad depression. Sometimes kids early onset can be very recalcitrant. And maybe it's because we're not doing a very good job sticking with the treatment because we're so worried about side effects. Some of us do that. As clinicians, we tend to give up on treatments very quickly. And that's a problem that we need to really understand before we really define treatment refractoriness like we do in adults who really clearly have had long stretches of treatments that have failed, and then you get to ECT or something else. But the other point to make about TMS and ITBS is that Nolan's seeing that the people who are responding the best seem to be younger. So this transitional age youth group seem to be like the 19 to 21s. The kids under 21 technically aren't FDA approved either. So he's asking me to kind of extend, some of his stuff. And I mean, I've learned how to do TMS. I have now the ability to implement it, but it's for kids, there's just nuances to it, and to be able to make it convenient and helpful. But what I would like to see happen is for us to be very mechanistic and very thoughtful about like what exactly are we doing. When we did the TMS study with Neuronetics, we were a multi-site for that industry-sponsored trial with Mayo and others, and they didn't see separation of effect from sham to real. And so, and I think that the lesson we learned there was that we targeted the DLPFC, but we didn't do a lot of developmental adjustments. So spatial resolution and targeting are really important. So Nolan, in collaboration with Keith Sudheimer and others, developed this targeted TMS protocol called SAINT that they're really trying to push forward. And I think Mark, they're going to plan to, I think, spin a company off of it. So the idea is to take a more targeted approach, personalize it to that person's brain, do a theta burst strategy, and then see and look for a response. But my interest as a scientist is always, okay, so you showed it worked in the acute phase. Tell me what it does in the long term. And maybe it's something like FFT, like where you see like no benefit in the acute phase, but like if you follow people out 2 to 3 years out, you see, whoa, the kids who got TMS or ITBS actually are doing great. And if you just stuck with following them for long enough periods, maybe you'd actually see some benefit. It's so interesting to me that kids offer the opportunity not just for understanding what we should do, but when we should do it. And that's where I think our designs need to really elaborate on, like, okay, do we do it at age 10 or do we do it at age 12? Is it too late by the time you get to 15? A lot of people now are saying in the business of our work, Martin and me, people are saying it's too late by the time you reach adolescence or puberty. You've done the damage, or you need to go perinatal or prenatal with your interventions, gene therapy to prevent mood disorders from lasting a lifetime. And that gets a little kooky, but I think that, we have some work to do just even in adolescence. Sorry, long-winded, but I hope that was helpful. And I think that I totally agree with you that modulation paired with a psychotherapeutic intervention or a pharmacological right now, most people are doing adjunctive TMS, right? They're doing.
But like you said, it's too difficult then to tease apart the effect of the stimulation itself, which is what we want to understand, right? So
and then you get into
really
the ethical
difficult.
questions.
Yeah.
Is like, do you give a sham treatment to a kid? And what are the liabilities of not treating a kid who's very, very depressed? So those are the things that we have to kind of weigh.
All right, I think we need to wrap up. Sorry, I forgot that Manpreet has another meeting at 1 o'clock. So my apologies. I think I looked at the old schedule or something. So I apologize for that. So thank you all for participating, and we'll see you soon again.
Thank you so much for your time and attention. Super appreciate it. And hopefully I can come to Oklahoma soon in person.
Yep.